My name is Cliff Robinson. I'm a professor of radiation oncology at Washington University in St. Louis. I'm the director of clinical trials and chief of the stereotactic radiotherapy and thoracic oncology services. So one question would be, how do we treat a patient where the tumor has started in one location and maybe just spread to a few locations, specifically a lung cancer that starts in the lung and maybe just goes to one or two spots somewhere else? This is something that's been really exciting over the last several years. Previously, we thought that it didn't really make a difference whether the tumor spread to one area or 20 areas, and we just thought of treating all those patients with chemotherapy alone. But what's become very clear with a number of clinical trials that have been reported over the last several years is that there is a benefit to more aggressively treating those areas with something like surgery or radiation, with the idea being that you can reduce the total burden of cancer the person has, and that may reduce the amount of additional spread that occurs later on. Now, none of those trials are definitive, meaning none of them have proven this definitively in a large FDA-approved trial. However, the early trials are quite interesting, and many of us are doing this for select patients outside of a clinical study, meaning that if you come to me and you have a tumor that started in the lung, and you've developed spots that have only gone to a few places, I can use that precision-focused stereotactic radiation to each one of those spots and very carefully deliver that treatment. And the question is always, why one patient versus another? And it becomes very nuanced because for some patients, those areas may be too close together. There may be too many of them, or they may be in sensitive organs that won't do very well if we're trying to do this in the context of the drugs that also have side effects. And so it's a very personalized decision for each patient.